the course of the next 3 days, I really urge everybody, I talked about this a little bit last night, to really participate. The really nice thing about conferences like this, and I will tell you that the faculty are all volunteers. And what that means is people are coming from as far as California to be here on their own dime. They're leaving work, they're leaving their families, missing a weekend, because this is near and dear to their heart. And that's, in organized neurosurgery and academic neurosurgery, it's one thing when we do things for work, we have to go to things. This is something that's voluntary, and you'll see the all-star faculty cast that we have here, and it's phenomenal. And it's such a rich resource. So what makes these meetings great, and I still can't believe every time I look at this, I echo Eric, 31 years. And I've been fortunate to be part of this probably for about 15 years, almost half. That means I'm old. And it's just to watch this organization grow over the years, and all the help it's given patients across the country is just incredible, as well as other physicians, researchers, and we have everybody in a room for the next 3 days. So please partake. It's a nice thing that this is a nice 300 people in a huge auditorium. So we really want participation. We want questions. We want discourse. We want to have the faculty. You're going to see one of the things. Chiari is, we understand anatomy. We understand a lot of these things, but this is one of the things in neurosurgery that a lot of patients we don't have great answers for. We still don't have a great understanding of many aspects of Chiari. And I think you're going to see that. We've really over the years instilled a lot of research components. And I think one of the talks, I think it's later this morning, but where we are with a very large prospective trial, even just trying to figure out, we all have always known pediatric Chiari and Syringomyelia is very different than adult. And for a very long time, especially during my training, that was kind of all lumped in together. And it's a very different process. It's a very different entity. So that is, this is just a fantastic venue for that. So I'm going to kick off the conference with kind of an overview. We're going to go to kind of 30,000 feet. And I've given this talk, I've given a bunch of different talks on Chiari, and this one I think is what I get the most questions as a Chiari neurosurgeon. In the Philadelphia region, I'm kind of the Chiari guy, for better or for worse. I get a lot of referrals, and over the years, it's, the most common question I get from my referring physicians, as well as from patients, are, how come I have a Chiari? And I know somebody that has a Chiari, but they weren't recommended surgery. How come? Or I have a friend who's had surgery, and they've had 50 surgeries, literally, and they had a shunt put in, and this didn't work, and they had to go back, and they had a spinal fusion. It's a very confusing entity. So what I've tried to do is to really, as much as you can in 30 minutes, kind of hone this down into really an overview of what we know, what we don't know, and to kind of categorize things. And a lot of it is really going to be my bias and what I've, over 15, almost 20 years of treating Chiari malformations, both in kids and adults, my thought process. And so that's what I want to start with. These are my disclosures, and I think the most important one is the first one. Everybody that you ever hear from as a speaker is biased, whether you like it or not. I'm biased. I'm biased because of my experience here in the city, which is maybe very different than Bryn's experience in Iowa. Patient populations are different, referral patterns are different, and you only know what you know and what you see. So you have to keep that in mind. Anybody that speaks, there's no true gospel. It's everybody's kind of collective opinion. So I want to start off, again, 30,000 feet. Chiari. All people who suffer from Chiari experience varied symptoms. There are some very common ones, but they are also varied. But it's also important to point out that many people that have Chiari have no symptoms. So it's not a given that just because you have a Chiari, you're symptomatic, or just because you have a Chiari that you need surgery. I shouldn't say many, but not a small number are incidental. They're incidental findings, and that's what's really important, because our treatment isn't trying a medication and seeing if it works or not, and if it doesn't, it's a side effect, okay, we'll switch to something else. It's surgery. It's major surgery, and once you entertain surgery, there's no going back. Once that incision's made, you're committed to that surgery and any possible repercussions from it. So let's go over Chiari symptoms. Pain is the most common one. And, it's amazing to me, my second, well, besides Chiari, what I'm known for is vascular neurosurgery. So I see a lot of patients, and I treat patients with ruptured aneurysms, acute stroke, and patients that are starting to go weak, they'll ignore weakness to the point where, they're dropping things all the time. But when pain occurs, that's what brings most patients to the doctor, is pain. And that's the most common presenting symptom of Chiari in any population. And the most common of the pain syndromes is headache. And we all talk about the classic Valsalva or Chiari headache that's in the back of the head, and you cough, you laugh, you sneeze, and it's like getting hit in the back of the head with a bat. That's, in my experience, and I think of most of the surgeons you talk to, that's the kind of classic, but it's very varied. It can be frontal, it can be temporal, it can be on one side. It doesn't have to be that. And I think sometimes doctors and neurologists in particular will see this, and it's not a Chiari headache, so I don't think it has anything to do with the Chiari. You really have to listen to the patient and understand the headache. Neck pain's a big one. Neck pain, stiffness, tightness, pain that may radiate, girdle pain, arm, leg, isolated, not as common, and you can see it gets less and less and less. It's usually in the shoulders and going down. Weakness, 56% of patients, and this is from a large series, will experience some form of weakness. Most times it starts off very subtle, and that's why patients kind of get down the road before this is diagnosed. And hand intrinsic weakness, the fine motor muscles in our hand, that's what people will notice. And when you ask a patient, do you have any weakness? No. Do you have any problems with your keys? Yeah, it's funny. I just think I'm clumsy. I keep dropping my keys all the time when I try to get in my house. The other day I dropped my coffee mug, which, I thought it was slippery. It's kind of these subtle things, but usually will start in the hands. And then it will progress into, if it goes down the line, into arms and legs. Numbness is another common one, and it can be really in any distribution, but it's usually shoulders, upper extremities is where you'll feel it. Sometimes if it's a severe Chiari and brainstem, it'll be in the face as well. Loss of temperature sensation is another big one, usually in the hands. So I'll see patients and I'll know right away when I come in and I see their hands are just covered in burns, old scars, cuts, things like that. So you have to kind of pay attention to that as well, particularly in the right hand. Most people are right-handed and they're doing something on a stove and they're burning themselves because it's a slow process. If you wake up and your hand's numb, you know it. If you're sitting here and you have your elbow up or your legs crossed, you immediately know when your leg or arm's numb. If it's a very slow process over months and years, you kind of adapt to it, so it's not as obvious. Unsteady gait is a big one. I'll ask patients all the time, have you had problems walking? No, I'm fine, no problems at all. How about going up and down steps? Well, I've been kind of tripping a little bit, but I think it's a carpet on the steps. Again, people will kind of adapt and make excuses, but unsteady gait, and it can be just a new clumsiness, bumping into things that aren't normal for you. Double vision, not as common. There's usually some type of visual symptoms. One of the things we'll talk about is nystagmus, where the eyes will kind of beat very fast, and you can see patients will describe it as kind of a shaky, but it's usually not double. Difficulty swallowing. I think in this series it's smaller. I see, I would say at least 20% of my patients who are symptomatic Chiari will have some type of swallowing difficulty. And again, it's usually subtle, but they will complain of that. Ringing in the ear. This is one that gets dismissed a lot. Tinnitus, ringing in the ear. It can be a one side or both sides, very common. I dismissed it early on because, as egghead academicians, we're like, well, it's a very rare cause. But after years and years of doing it, where patients will have ringing in the ear, they have other symptoms, and then after the surgery, the ringing goes away. It's a pretty common thing. And then miscellaneous, dizzy, fainting, the face numbness. Hiccups is another one that's you'll see with these kind of hiccups where people talk about it, and again, it gets dismissed a lot, but everyone's had hiccups in this room before, but if it's a recurring thing and you're having it all the time and it's really difficult to relieve, that also is a sign. So those are symptoms. So those are things that as a patient you feel. signs are things that we're looking at as a physician, or signs that you're exhibiting. So one of them is what I talked about before, nystagmus, really fast beating of the eyes, particularly upbeat. When you have a patient look up like that, you'll see kind of either a bobbing or looking from side to side, a very fast shake of the eyes, and that comes from brainstem findings. Difficulty with gait, and again, it can be subtle. You have to have a patient walk up and down a hallway. Now, if I have a 78-year-old patient, who's had 2 knee replacements, I understand what their gait's going to be. If I have a 20-year-old who, is playing softball in college and she's walking up and down my thing, she should have perfect gait. There shouldn't be an issue. There shouldn't be, when you walk, a little bit of a stutter when you turn, and a little bit of trying to kind of gain your balance. That shouldn't occur in a healthy 20-year-old, so it can be subtle. Clumsy, frequent falls, bumping into walls, bumping into furniture. Patients will have bruises on their legs. Hand atrophy is a big one that we look for. So when I'm examining a patient, I'm not asking them to let me look at your muscles. I'm looking at it in its natural course. You can see, especially the muscles in the thumb and the forefinger here, the thenar eminence. You'll see these muscles that just waste, and that tells you that that's a chronic process. Weakness, especially in the arms. Patients will complain of a heaviness in the arms, where it's just kind of putting her up. I've seen many, especially older patients, get misdiagnosed with rotator cuff injuries, shoulder injuries, undergo unnecessary shoulder surgery for this, and it turns out they have Chiari. It's usually both arms. Patients will normally complain of their dominant arm. They'll say, oh, it's really my right arm, but you haven't put them up, and it's usually both. And then the classic is, which, and I'd love later to poll our faculty, I can count on my hand of the probably 1,000 Chiari patients I've seen in my lifetime where someone comes in with this classic cape-like distribution. And everybody in this room, and don't lie, you've been on the internet, you've Googled, you look stuff up, which is okay. I think it's a good thing as a doctor because the patient's more educated, and at least then we can go over kind of what fits specifically for you that you've read about. But you'll see this classic in all the textbooks, cape-like distribution, right? It's pretty rare. It's a little bit more diffuse. It fits more with anatomy than reality. And then fasciculations. That's just the muscles that are basically having their nerve innervation interrupted, and you'll see these like twitches. And patients will feel it. They'll call it a tremor, but you'll get twitches in your legs, in your arms, and particularly in the hands. And again, those are signs that this is kind of far along. So this is a big one: fatigue, depression, memory loss. And this is a really, really important one. It's one to understand. You're going to have some great speakers talk about this. In particular, I wanted, over the years, I'm still not clear and understand where memory comes in with Chiari. Anatomically, it doesn't make a lot of sense. There's no direct thing, but I don't dismiss it anymore because a lot of my patients have it. But it's multifactorial. One of our speakers, Peter Glebus, is the head of the Cognitive Center at Drexel, who's just a brilliant physician, and this is what he deals with, and we see patients together all the time. And so he's going to speak a little bit about that, about the reality of memory loss with Chiari. But fatigue, depression, memory loss, these are multifactorial, and they're real. And I think a lot of times patients either feel, which is just as important as actually being dismissed, but they're from a constellation of a lot of different things, what are real things that are real chemical imbalances in the brain. Misdiagnosis and poor communication worsen. The patient that goes down the line with all these symptoms for many years, and they don't know what it is, but they know it's real. They see lots of doctors, they try everything, and then finally, and sometimes of their own demanding, I want an MRI of my brain. That frustration, that process, that really wears at you, and that really worsens the above. And that's why our job is to really education, understanding, will really reduce, in a lot of cases, relieve that. I can't emphasize enough how important communication is with the physician and educating to make sure that everybody's on the same page and they understand what's going on. So, the old saying, especially in vascular surgery, is, the devil's in the details. It's the little things that are the big things. And I can't emphasize enough that, the end point here is surgery. When you're seeing a Chiari patient, your determination is, am I going to help you by giving you surgery? That is a huge, huge decision. That's a life-altering decision. And as a surgeon, I take that very seriously because I own my patients, and I think I speak for most of my colleagues. We own our patients. If I operate on a patient and they don't get better, I can't just say, well, I'm done with you and we tried surgery, it didn't work. You have to kind of go through, and there's no worse feeling for any type of problem, whether it's somebody with low back pain and you do back surgery, or someone's having seizures because they have a large AVM in their brain. We want our patients to get better. And when you commit them to surgery, you kind of own that. So you really, really have to pay attention to the details. And headaches is the big one. I cannot tell you, most of my Chiari clinic are patients that are referred to me because they have headaches, and they're found to either, many patients don't have a Chiari and a radiologist is over reading a film. And my chest pain is that this patient's going to go out somewhere and they're going to get surgery they don't need. Not only their headache's not going to get better, they're going to get a surgery that's probably going to make things worse. So it's important to understand that there are over 100 types of headaches. And I believe my chief of our headache service said there's 150. I challenged her to tell me all 150 and she couldn't, but the point is there's a lot of different headaches, and each headache has to be diagnosed for the type of headache it is because each one has a different type of treatment. Pain is really common, but it almost always fits a pattern. So when a patient comes in and they're having these diffuse headaches, where does it hurt? Everywhere. Well, where? My whole body aches. I'm sore everywhere. I can't get up out of bed in the morning. I start to shift. Now, again, it's important. That doesn't mean that's not real. It doesn't mean that that's any less important or severe, but what it means is I have to be thinking, if I do surgery on you, is that going to get better? So I have to put my doctor hat on and take off my surgeon hat. Weakness is also specific. The generalized weakness. I'm just weak all over. I just don't have strength. I don't have energy. The weakness is my hands, my arms, my legs just feel weak. I'm out shopping, and after 10 minutes, my legs just give out. I have to sit down. That's a very different weakness than just generalized weakness. And if the symptoms don't correlate, you're not going to get a good result. The two things you have to mesh are the imaging, the MRI, the symptoms of the patient, and everything has to kind of fit together. If they don't, and there's a mismatch in any of those things, almost always you're not going to get a good outcome. Here's another big one, and I hope this brings some discussion, and I'm not known to be shy in my community, and I will say this, and sometimes it's controversial, but you really shouldn't be having more than 3 surgeries for Chiari. There's always complex cases in every type of surgery, but how many people in this room, and whoever's comfortable, again, we're all family for the next 3 days, right? How many people have had more than one surgery for Chiari or related? Got a couple hands. How many people have had more than 3? 5, 10, 20. Okay, hand went down at 20. So, again, there's always varying aspects, and there's different complications that occur. But if the first surgery does not help you, it was the wrong choice. And again, always exceptions. But when patients come in and they have severe hand intrinsic weakness, they have ataxia, they're having problems walking, they have these horrible headaches, and I see them post-op, and their symptoms aren't, no, they're going to have neck pain from the surgery and things like that. But overall, my question is, are you the same, better, or worse? And if it's not better, then I did the wrong thing, almost always. Because the goal of surgery, for the most part, is to relieve symptoms, one, but also to prevent progression, which is another thing. So those are some of the exceptions where patients are just going down a course like this. So it's an important factor, and that's where the devil's in the details. So facts and thoughts. 30% of patients are asymptomatic. So think about that. This is data that we have. 30% of patients that have an MRI that have a Chiari are completely asymptomatic. I have a lot of those patients, and I see them every year in my office. Get a checkup, they get their MRI, come with their MRI, everything looks okay. Some patients I'll even hold off on the MRI for a couple years, 3 years, unless they're having symptoms. Because if they're not having symptoms, there's not much I'm going to change. Now I want to see them in the office to examine them to make sure they're not having that early hand intrinsic weakness, that their walking's okay, and generally check in. But the point is that not every Chiari is symptomatic, meaning it doesn't need to be treated. There's an asterisk on this. No one dies of Chiari, and that's one of the things that I reassure my patients the minute they come into the door, because if you pull somebody off the street and tell them you have a Chiari malformation, you're thinking, holy S, you know what? What does that mean? And then you get on the internet and you start seeing these horror stories and people freak out. So I really reassure people, when I have a patient comes to me and they have a brain tumor, I have a different conversation. When somebody comes with a giant aneurysm that is going to rupture over their life if we don't treat it, that's a different conversation. My Chiari patients, I reassure them that you're not going to wake up paralyzed. Don't get scared into surgery. There's nothing worse than my second and third opinions where, I was told by so-and-so that if I don't have surgery in the next week, I could be paralyzed. That's bull, you know what. That just doesn't happen. So it's important to put that in context. And again, surgery is not a trial. It's not a trial. It's permanent. Once you commit to surgery, you're committing that patient to surgery. And the way I think about it is, would I do this for my daughter? Would I do this for my mother? Would I do this for my brother, my sister, my friend? And it kind of changes your perspective. And again, choose a treatment for the condition, not the symptom. If I rarely, and everyone has a different thing, and there's no right or wrong answer, I will rarely operate on a patient solely for headaches. If everything is completely okay, neurologically, there's no other signs or symptoms, and it's headaches alone, I generally will not do the surgery, because to me, and again, in my practice and my experience, it's a crapshoot if it's going to get better or not. So I'd much rather have them go to a doctor I trust, who's not just going to throw a ton of medications at them, but is going to work through what their headache is, why they have a headache, and try to treat it in a conservative way. Now, that being said, it's important not just to write a script or just tell a patient, well, go see a headache doctor. Okay, so how many people here have seen a headache doctor who specializes in headache? Go ahead, I want arms up. I know, because I know there's some of you and I know you have. Okay, how many people here, hands up high, think it's easy to find a headache physician and get an appointment with a headache physician? No hands, and that's right. It's really hard. So again, you have to own it. We one of the things we did in the last several years, we have a neuropharmacist. We brought our own, and you're actually going to hear from her. She's brilliant, Natalie Goffman. So when I have patients with problem headaches, I know that at some point the treatment's going to be pharmacotherapy or medications, and I'll let you know a little secret, okay? A little secret, a little physician's internal secret. We do a really crappy job managing medications. We really do. Because back in the day, when I was a youngin', in neuro, there was a pretty small subset of drugs we used. There were the anti-epileptics, antidepressives, antiplatelet agents. Back then it was just aspirin. We had a small pool to choose from, so you knew a lot about those medications. I can tell you every day, I will look at something, and I have no idea what the medication even is. First of all, there's 50,000 different name brands. The generics there's new things out there. So the point of this is I need somebody who that's all they do are medications and know every single profile, are going to sit with the patient, take time to go over all the medications that they're on, see what's interacting, more importantly, see what's not working and take them off of it if they're not. So, you have to, the headache is a different thing. So you don't treat the symptom, you treat the condition. And here's another big one, controversial. The degree of herniation is, I don't even pay attention to it. I don't listen to it because I've had patients who have borderline Chiaris and it walks like a duck, talks like a duck, looks like a duck. They have every single classic Chiari symptom and they do well with the surgery. I have patients where I look at the MRI and I get sick to my stomach. It looks so horrible and they're completely intact. So, you have to not just go by this number, and it's funny because some patients kind of have, I've got 9 millimeters of descent, I've got 12 millimeters of descent. That number is a number. You really have to look at the films and correlate that with the patient's condition. So the initial visit, the first step is, when a patient walks in, who to offer surgery to. That's really what, I'm a surgeon. If you go see a surgeon, that's what the decision process is. So that's number one. Who to follow? As a Chiari surgeon, you have the responsibility of following these patients. Anybody that just says, well, you're not a surgical candidate, I never want to see you again. If in fact you have a Chiari, that's, we're surgeons, but we're also doctors. So as I said, I have many, many patients in my clinic that I follow who are just yearly follow-ups, 2-3 year follow-ups. So you have to know who to follow and who to help. That's a big one. But we talked about the headaches, well, you just have headaches, we're not going to deal with this, but who to help to take the time to basically get that patient to the right person, to help make that referral, to pester the doctors, to get them in, to see them, to kind of talk about them and not just kind of sign off on them. And again, the biggest one, this is the holy grail, patient selection. Every patient is different. And I think that's what the most amazing thing to me about medicine and surgery is that, it's not cookbook. It's never cookbook. There's an art to medicine that unfortunately I think is getting a little bit lost, but that patient selection of understanding each individual person, the symptoms, their films, all those things collectively. Now, do a lot of things fall into categories that are common? Of course, but you have to select your patients very, very carefully. So thoughts, and again, these are mine. This is just from my experience. They're not right, they're not wrong. They're kind of just, over a long time of doing this. I think most people agree with this now. They didn't before, but with Dr. Keating at DC Children's, we're doing a study now where we're actually 5 years ago, we talked at the Chiari meeting. He does exclusively pediatric. The great majority of my practice is adult. We all know adult and pediatric Chiaris are not the same. When I trained here at CHOP, people, people rotating through would basically say, yeah, they're kids, they're just little adults. That's like the classic. And if you ever want to really piss off a pediatric neurosurgeon, tell them that. It's not true. It's a very different population. It's a very different process. It's a very different logarithm, everything. So we're in the process now of looking at different characteristics between the two and seeing, what is different, what is common, and what procedures we should do that are going to help the patients more. Age is not a limitation. The oldest patient I ever operated on with a Chiari was 89. And she was completely independent, living alone. As a matter of fact, she actually was driving her 50-something-year-old son around because he was disabled. She was still being a mom to a 50-something-year-old person, completely independent. And over a 6-month period, she went from a cane to a walker to a wheelchair. And she had a horrific Chiari. So we had a long discussion about whether, and she said, I'd rather be dead. If I have to be in a wheelchair for the rest of my life. So we had a long discussion, we had a family meeting, and she did great. Her sole symptom was gait. That was it. She just couldn't walk. Her balance was so bad. She had lower extremity weakness, and it was an acute period. And she's walking. She was. This was years ago, and I'm sure she's past this point. But her, I think I saw her up to it was like her second year after, and that was this. I was like, no more films. You're done. Don't see any more doctors. And then the youngest is, in the pediatric population. But age is not a limitation. Again, every case is unique, and that case illustrates that. Getting back again to hammer home, 1% of all MRIs show an incidental Chiari. So if we walk out into the street of Philadelphia and 1 million people, 1% of these population is going to have a Chiari. So that's 3 million people. That's a lot. My suspicion is it's probably higher than that. Because this is obviously a number that's been generated, but incidental Chiaris are not that uncommon. So let's go through a couple specific patients, and you give me my, oh great, perfect. JS is a 25-year-old female, really active, started a new job as an executive, and just a complete type A personality. She started having really bad neck pain. She thought it was her computer at work, and she just kind of went downhill over about a 3-month period. Lack of energy, really bad headaches, got a lot worse around her period. All these things together, because of the headaches, her primary care doctor kind of light bulb went off, and she got an MRI. That's her MRI. And you can see that there is a, let's see. There we go, great. You can see here's a Chiari, and you can see there's the descent, and I would say this is a Chiari. It's a what it means, mild, moderate, severe. This is a Chiari, And so I saw the films. I wasn't that impressed with this based on her symptoms. So again, let's go back to our process. We've got to correlate symptoms, films, and listening to the patient. So, I saw her in the office, and she has a really high-stress job. She just became an executive, which she realized that, everybody wants to be in a leadership position. Once you're in a leadership position, you got a lot of things that you didn't have to deal with before. She really wasn't sleeping well at all. Her neck hurt. So I said, does it hurt when you push on it? Yeah, she had trigger point. So you go the back of her neck, all the way up and down her paraspinal muscles, and it hurt when she pushed. That's a big, big sign. Chiari, any type of neurologic pain, whether it's a ruptured disc pinching a nerve or anything from your brain that's neurologic, is not going to do that for the most part. Is not going to do that. That's ligament and muscle pain. So that's from doing this all the time. That's from sleeping on a wrong pillow. That's muscular. And then we talked about her headaches. She's had migraines since she was a child. They went away in college, and now they're coming back again. Really sensitive to light. She wears sunglasses when it's bright out. Loud noises. And I said, what do you do to treat these? Go to a dark room, shut the door, and I just lie down. And I can't do that now because I'm working all the time. But that's usually what takes care of it. So those are classic migraines. That's a classic migraine. Her exam, she's completely intact. Her reflexes were a little brisk, and that's why she saw a neurologist who sent her to me because she's hyperreflexive. A 25-year-old female is the great majority of them, and when we're talking about that is, you do the knee jerk, it's a little bit more brisk, but everything is symmetric. It's the same on each side, normal. So the plan for her. So I will tell you that she has a Chiari. She's got Chiari symptoms, which you can put in the textbook as classic. Now, would anybody be faulted for saying, hey, you need to be evaluated for surgery? Absolutely not. Absolutely not. But this is where the devil's in the details. The last thing this woman needs is surgery. The absolute last thing. Her headaches are classic migraine headaches, which have nothing to do with her Chiari. Her neck pain and soreness is 100% from positioning and her sleep and lack of sleep. So I saw her back in 3 months with those types of things. We got her connected with the headache center. We changed her sleep habits. We got her. She got one of those Tempur-Pedic pillows, and she came back. She was just like, she hugged me. And usually you get hugs after surgeries, and people do well because she did not need surgery. So this is another important thing that I want to get back to is the change in habits. So our imaging is important too. Knowing what type of imaging. Somebody just comes and has a Chiari or something like that and the symptoms don't make sense. We now have a lot better imaging modalities that we can get to help sort this out. So this is the same patient getting an MRI. This is sitting and this is lying down. Look at the level of herniation of her cerebellar tonsils here and then up here. So there's variation depending on the position of the patient while the MRI is being done, blood pressure, there's lots of different variations. And one of the keys to me of what I think the goal of surgery, at least my goal is, and what I get my results with, are relieving this blockage of flow. And that's really the epitome of what a Chiari malformation is. Cerebral spinal flow, you see the white fluid here, you see it back here in part of the brain back here. When there's an interruption of flow, that's where all the problems come. You're getting a stopgap, you're getting a cork in the bottle. That's where the syrinx comes from. And at NIH years ago, Ed Oldfield did just some brilliant work on this, not in a lab, not with patients, and really trying to understand this. The fluid, the pressure here is a lower pressure when there's no blockage. When there's a blockage, CSF pressure builds up here and it's pulsatile during different times. The fluid pushes into the center of the spinal cord, and there's a very thin canal here called the central canal that's normal. Now, normally you can't see it because it's so small, but this fluid seeps into that. That's where the syrinx comes from. Symptoms from the back of the head, about that bad Chiari headache, when you cough, you laugh, you sneeze. There are very large venous sinuses back here that are very, very large. And when you cough, you laugh, you sneeze, you bear down, they get engorged, and it further worsens that, and that's where those headaches come from. So what I want to know is there blockage of flow there? And this is a Cine flow study, which is a dynamic real-time And you can actually see, these are actual pulsations of a patient on an MRI, and you can see that fluid, and this is a normal patient actually, and you can see the fluid. Oh, it's going up on here and not on there. Anyway, you saw that fluid pulsations going back and forth from here. That's telling me I'm not going to achieve anything from the surgery. So that patient, I'm not going to do anything surgically if the fluid's already free there. So you can see that fluid pulsation. You see that white going back and forth. Now let's shift to a different. So this is a 42-year-old female, mild headaches. Ask her where the headaches are, kind of in the back of the head. They radiate forward, cough, laugh, sneeze. It makes it worse, but they're kind of there all the time and they're getting worse. She's dropping objects. She's noticing this, and it's very unlike her. And that's the most upsetting thing to her because she actually was worried she had MS, and some idiot told her she had MS. She has neck pain, but it's a deep pain. Like, where is it? Does it hurt when you press on it? And it's like, no, it's just deep. I can't get to it. I put heating pads. I put cold. It's just really deep, and I just can't get to it. And she feels unsteady. So she feels like she's drunk. That's her MRI. Now, this is a correlation. This is where cerebellar tonsils are. I mean, most of her symptoms, especially the balance and all that, are coming from, she's literally stretching her cerebellum, and her brainstem are being pulled down. And so this is a very severe Chiari, and this is a patient that has classic symptoms. Every day of the week, this patient needs surgery. And this is also a patient that I don't want to wait 3 months, 6 months for, because her symptoms are getting worse by the day and by the week. So this is somebody I want to decompress sooner than later. And, again, the goal of the surgery, we'll get to that. So on our office visit, ringing in the ears, difficulty swallowing, headaches are worse, especially when she's lifting. She didn't even mention these. This was after going over and saying, do you have ringing in the ears? She's like, yeah, you know what, I do. I didn't think about it, and I didn't connect anything. Difficulty swallowing. You have to ask the questions because sometimes they're subtle, and they started to recently occur. Her exam, she had her hands had atrophy. They were wasting, like we talked about earlier. She had a decreased gag reflex with a tongue depressor. Very ataxic, and her balance, and it was not just her legs, but her trunk, her body was actually ataxic. She also had a little bit of a tremor in her trunk, which is unusual, but clearly related. So plan, again, surgery. So this is the goal of the surgery, right? We want to go from this to this, and there's a CSF. She now has cerebrospinal fluid. This is just sagging because this was just pulled down. I mean, so this isn't just going to spring back up. She's 42 years old. She's had this probably in some form since childhood, and her brain and her body have just adapted to it until there's a point of no return. But this is the goal right here, is restoring that CSF flow. It really comes down to that. So now some of the associated symptoms, and we have a great lecture on all the various associated symptoms, which I think is one of the more important lectures. One of the big ones that you have to look for is when a patient has a Chiari is 1, hydrocephalus, which is very common, and 2 is syrinx. And the hydrocephalus isn't always obvious. I have a patient, a young girl who Dr. Hidayat knows, my whole team knows well. I mean, she's a young girl who basically had hydrocephalus as a child, and it just wasn't obvious on her MRI, but she had a pretty significant Chiari with Chiari-like symptoms. Her ventricles weren't big like this, and we treated the Chiari first, but the wound kept opening up, and that's a sign that there's hydrocephalus. So we then treated the hydrocephalus. But this is something you have to rule out up front. If you see a patient like this, I personally treat the hydrocephalus first. This is a pressure phenomenon. As the ventricles get bigger, it's pushing down the Chiari. And I have several patients where I shunt and the Chiari just basically either stays stable and all the symptoms go away, or actually the Chiari elevates, unless it's really severe and it's kind of down like this. So you have to get an MRI of the brain to make sure that there's no hydrocephalus, and you have to look at the spinal axis to make sure that there's no syrinx as well, so that we know what we're treating. So with hydrocephalus, you have to rule that out for every Chiari patient. And my logarithm is I will treat the hydrocephalus first and then the Chiari second if it needs. If you have a patient and they keep coming back with CSF leaks after a good repair, that's hydrocephalus until proven otherwise. And that will, because that pressure is just building up, and you have a fresh incision line there where if you're sewing a patch in, it's just going to keep popping a leak every time because the pressure is going to be greater than the strength of the stitch. So treatment. And again, I don't mean to simplify this, but I'm a simple person, so I try to keep things simple. My goal is to do that decompression. And people talk about, again, we're talking about the run-of-the-mill average 90% Chiari. This is the surgery. We're removing a little bit of bone back here to get access to that craniocervical junction. That's about as much bone as we want to remove. And you all ate breakfast already, so and it's black and white. I mean, I didn't want anything bright red and bloody and brain early in the morning for you, but this is it. This is an exposure for a Chiari. These are the tonsils that are herniating down, and this is the dura. So once I have this exposed, there's that bony removal. Personally, I shrink these because I want that. When I look through, I want to see that you can drive a truck there, where it's just wide open fluid. It's not bony removal; it's just opening up back here. So I will shrink these up here with cautery, and then we sew a patch in here because I want a nice wide open space. Now, some people don't cauterize, and I'm talking about for the adult population. It's a different thing, and I'm curious with the panel with our pediatric colleagues of how many people now are opening the dura. Because that's when I was training, very few people open the dura. There's usually this really tight band here, a ligament, that before you even open this and saw the brain, you cut it and everything would kind of pop open. And the kids did really well with that. What I started to see in my adult population, and I'm in the same city, I was at CHOP, I see some of these patients coming back who then needed Chiari surgery 10, 20 years later as adults. I don't know the answer to it, but it's something that we'll discuss with our colleagues. So Syringomyelia, I'm not going to get too much into this because we have a talk specifically on that. We talked about etiology and how that cyst forms. This is a classic Chiari. This is one of my patients. You can see the Chiari there. Again, we talked about the cerebrospinal fluid going to higher pressure to lower pressure. Once this stopgap is open, you take the cork out of the bottle. Now the pressure here is higher in the cyst than outside the cyst. And that's why almost always between 6 months to a year, the great majority, I would say upwards of 80%, this completely goes away. Now, patients are very fixated on that, especially when you show them these films in the office and you see this. If I told you that you had this huge, here's normal spinal cord, and that your spinal cord is this little ribbon on each side, there's this big cyst, rightly so, patients are fixated on that. Like after the surgery, even if they're feeling great, they're like, how's my syrinx? Did it get bigger? Is it smaller? Patients that have had this chronically, sometimes it won't go away. And it's okay, but the pressure's out of it, but it's been stretched for so long that it's just a compliance issue. So I don't get overly concerned, as long as the symptoms are better. So speaking of that, I have a patient, she's a sweetheart. I've been following her for a really long time. She's asymptomatic. She's a type A times 50. She's a Spanish teacher. She does like 50 different thousand things for everybody. She's an amazing person. And she came to me because her doctor made her come because she got an MRI because she was having some bad headaches and she was having some numbness in her hand and he thought she had a stroke. She had baseline tingling in her feet and she's got an MRI. Actually, I'm sorry, let me go back. That's her. She got an MRI and she has a Chiari in this and she absolutely refused surgery. And these were her symptoms. And at the time, I basically pleaded with her. I said, it was one of the rare times where I actually was kind of like, you need surgery. This is going to get worse. And she is now in her 70s. And I just saw her a few weeks ago in the office. No problems. She has absolutely no problems at all. So she refused the surgery. I don't know, but the bottom line is, syrinx you have to understand the syrinx. Not all syrinx alone have to be treated. In general, and my policy is if you have a Chiari and a syrinx and you're symptomatic, you need surgery. But there are exceptions. So here's another exception. This is a common one that we see and a lot of confusion appropriately among patients of, I have a syrinx, I must have a Chiari. Or I have a syrinx and it's causing problems, which they often do, and it needs to be treated. Well, here's part of the problem, and I'm curious, we'll have, again, more conversation with our faculty, with everybody. This is a 56-year-old who had major trauma from a massive motor vehicle accident for 29 years prior, he was in a coma. He had spine surgery. He was in a really bad car accident. And then, interestingly, delayed, he developed very severe burning in a band-like distribution around his chest that was just horrible. It was, again, a deep burning sensation that nothing relieved, nothing would help, and he really didn't have any other symptoms. And this is what he has. Whoop, sorry. He has a syrinx, but way down here. What's different about this? Where is this? That's the syrinx. The white is the fluid. That's a cross-section of the syrinx, and the gray around it's the spinal cord. This is down here. This isn't up here. It's not as common, in my experience anyway, it's pretty uncommon to have an isolated thoracic syrinx with a Chiari and nothing cervical. Does it happen? It does, but it's not as common. When I see this, I almost always, it's trauma. And sometimes patients won't even remember they had trauma as a child, but this is clearly from his trauma. And these are a real problem. There's not a great surgical solution from these, and one of the knee jerks is, well, we're going to put a shunt in this. We're going to stick a little tube in here and drain it into the cerebrospinal fluid space here. They clog. Getting there can also be a problem. I don't think it's as much of a problem. I think sometimes we overreact to putting the tube in. I think it can be done fairly safely. The problem is they generally don't work. They don't last long. They get clogged, and it can cause other symptoms down the road. So these aren't a great solution. And for this gentleman, it was a pharmacotherapy. We helped him with his burning pain because he had no other symptoms. But again, the syrinx are multivariate, and the majority of them are associated with Chiari, 70%. So when you hear syrinx, almost always people associate them synonymously. You have to rule out a cystic tumor. Every syrinx that you see, for the most part, and certainly something like that, I got an MRI with contrast. You have to do an MRI with contrast because most tumors of the spinal cord will present with a somewhat cystic component. And sometimes they can be purely cystic, can be like a low-grade astrocytoma, an ependymoma, other types of tumors. So you can't just assume it's this and then brush the person off. You've got to get a contrast study. There's no lighting up of contrast, then we're safe. Trauma, again, the most common after Chiari is trauma. Basilar invagination, which we have a great talk about craniocervical instability, where you can see it with that. And again, you can see, so these sometimes are really not subtle. And sometimes they become loculated, where there's a cyst within a cyst. But this, when I see something like this, where it's irregular and there's cysts, this is what really, really worries me for a tumor. And again, they can have varying MRI characteristics, so you really want to make sure you get a contrast. And then let's just talk about the Syringomyelia symptoms briefly, because we have a great talk on this. Pain is the most common, and it's a different type of pain. It's not a headache. It's a burning, what we call dysesthesia. It's a dissociated type pain, which is really the worst type of pain you can have. And people that you may know of that have, it's not even a fibromyalgia. It's like a chronic regional pain syndrome. These severe things where people get ketamine infusions and are on a lot of different types of pharmacotherapy. The classic is a sensory loss or a dissociation. It's a loss of pain and temperature sensation, but they feel you touching them, but there's a disconnect there. Or you're touching somebody, you can feel them, but this light touch is perceived as basically somebody taking a hot iron and putting it on your hand, or sharp pain. Clothes hurt them. Any type of touch, it can be extremely painful, and you can imagine what that's like, living through that and having that kind of problem. It's horrific. Weakness, especially in the hand and arm, almost always in the hand, especially higher up. Very, very classic. And we won't get too much into that. So I'm going to close with some advice here. You are your only proponent, so don't count on anybody else, and don't be afraid to push and to ask questions. If you're not getting the questions you want, you need to move on, and don't feel that you have one stop. And sometimes it takes turning over a bunch of rocks, but you have to, if you're not getting the right answers, you're not understanding something, it is your doctor and your healthcare provider's job to make that very clear to you. Speak up. If you don't understand something, again, speak up. That's what you're there for. Don't worry about the doctor's feelings or if they get offended. If somebody gets offended because you're getting frustrated or whatever, then you need to find another doctor. Get a second opinion. I tell all my patients, especially before I do surgery, get a second opinion. You're not going to hurt my feelings. Ask somebody. If you're confused about what they're saying, that's fine. What I don't think is a great idea is getting a third and a fourth and a fifth and traveling around, because then it gets confusing. Then, because I think if I've done anything, I've illustrated, we don't have all the answers to these things, and there are different ways of doing things, and they're all okay and acceptable, again, but it's individual for the patient. So when you get past 3 and 4, it gets a little bit confusing. Internet is not a bad thing, but it's only as good as its source. So you have to take it with a grain of salt, what you see. And when patients post things, you have to keep in mind, most patients aren't going to post their surgery and their experience when it's great. They'll usually do that for the doctor review or something. People will go where they've had a bad experience or there's a complicated thing, which is okay, but keep that with a grain of salt, because the only thing that I don't like about it is when patients are diagnosed with a Chiari and they just become horrified because they see all this stuff, and you just have to sort it out. So my treatment paradigm: symptoms first, MRI second. Exam, what are the symptoms? They have to correlate. Early symptoms, and it's a mild Chiari like that one that I showed you, I follow them. I'll follow them closely, because the patient's not going to die, and it's not an acute disease. They're not going to wake up paralyzed. As long as everything's stable, we'll follow it. No symptoms, or signs, no surgery, period. I don't care what the MRI looks like. If you are intact and you're not complaining of anything and you had an incidental MRI, and you don't need surgery. Any motor weakness, especially in the hands, problems with balance, brainstem findings, I will recommend surgery. So symptoms or Chiari are definitely multifactorial, patient-specific. MRI findings do not always correlate with the clinical symptoms, and often don't. Chiari is treatable, curable. Right patient choice is essential. I tell my patients after surgery and their symptoms are gone, I said, you don't have a Chiari anymore. We anatomically, your Chiari is taken care of. You can deliver a baby with a vaginal delivery. You can go on a roller coaster. You can lift heavy things. Now, this is after they've completely healed, because there's nothing more to herniate. The fluid pathway's open. So, again, that's a big thing. It's curable. Be vocal, be your strongest advocate, and enjoy the rest of the 3 days.